welcome you all to everyone joining us today for the 44th episode of the ORDI webinar series. I'm Dr. Jiny. I have over a decade of experience in genomics. I currently work as a senior project manager at MedGenome, and it's my pleasure to moderate this today's session. On behalf of ORDI, uh, I extend my heartfelt welcome to all the clinicians, researchers, patients, and caregivers who have joined us today for another exciting webinar. ORDI plays a very important advancing the awareness and understanding of the rare diseases by fostering a platform that brings together clinician, patients, caregivers, and advocate. These interactions are very important for deepening our understanding of the rare diseases, but also for strengthening the overall support system. Before before we begin the webinar, I would also like to inform that today's webinar will be recorded and this will be available on the ORDI YouTube channel. On today's topic is on metabolic epilepsy. When we hear the word epilepsy, we often think of the brain, but what if the problem is not just the brain? What if the root cause of this condition could be your body metabolism? So early diagnosis plays a very important role, and this is a very important and clinically impactful subject. And today we are honored to have to talk about this topic by Dr. Vykunta Raju. Just to give you a brief introduction about Dr. Vykunta Raju. Vykunta Raju is a professor of pediatric neurology at Indira Gandhi Institute of Child Health, Bangalore, and has completed his DM in pediatric neurology from AIIMS, Delhi. He has made a remarkable contribution to academic research with over 250 publications and 150 original articles and close to 15 major research projects. Dr. Raju is also a renowned author, having written textbooks on cerebral palsy and contributed over 30 chapters to other standard textbook in pediatric neurology. In recognition of his extraordinary work and contribution to the child neurology, he was honored by the Associate of Child Neurology India in 2024. It's truly a privilege to have Dr. Vykunta Raju here. Over to you, sir.
Very good evening to all. So at the outset, I thanks organizers Dr. Prasanna Shirol and also ORDI India team for giving the opportunity to speak on this subject. And also I thanks Dr. Jiny for giving such introduction. So today I'll be talking on various causes of metabolic causes of epilepsy in children especially, and maybe it is applicable in older people also. This is the outline of my presentation. Initially, I'll be talking about what exactly the metabolic epilepsy. And there is a lot of overlap between metabolic versus genetic because many of metabolic are inherited. So briefly about classification, various classification, how they are useful day-to-day practice when you are dealing children with metabolic epilepsy. And I'll be talking most of my talk with the various case scenarios, what you are seen over a period of 1.5 decades, and how to approach these children and how to manage. So, as you know, the Hierly 2017 has classified etiology of epilepsy in various subcategories. So, whenever you're identifying any child or adult with epilepsy, you should give etiological classification. So, in this etiology, metabolic is one of the major subcategory, comes under etiological classification. Total 6 categories. So, in that, metabolic is one of the category. So you should try to find out any probable causes for epilepsy, especially after ruling out the structural problems, especially in Indian setup. So metabolic is also one of the important cause. So what exactly the metabolic epilepsy? Basically, they are inherited condition. As I told, most of them are inherited, and where the seizure is because of metabolic defects. Even though they are rare individually, but if you combine together, it is a significant challenge, especially in the pediatric neurologists and causing pediatric epilepsy. And the diagnostic evaluation and therapeutic approach usually different from commonly what you will see in routine epilepsy children, because the investigation are different and drug up selection is different. Some of them may not require drugs, so basically you need to correct the underlying metabolic defect. So ILES defined metabolic epilepsy as it is a condition where the distinct metabolic abnormality that is mainly responsible for increasing the risk of epilepsy in any individual. So that is called metabolic epilepsy. So we'll get basically two sets of metabolic epilepsy. One is where in the small babies, especially newborn babies, where epilepsy is a major manifestation of a metabolic condition, where commonly seen pyridoxine dependence epilepsy is the most common. Like that, many of them, like non-ketotic hyperglycemia, there are some of the examples where predominant manifestation is epilepsy starting from newborn period. In other condition, maybe an epilepsy comes maybe once in a while, like in case of large molecules. Sometimes in the world, like cycle disorder, some minor defects where the can present the seizures only during the episodes of stressfulness or encephalopathy. They can have seizures. So these two categories are different. So you should be aware. As I told, there are a lot of overlap between metabolic and genetic epilepsy. This is a pie diagram showing that there is a lot of overlap. So you should be aware that some of them have a same defect that can be classified under metabolic and under genetic etiology also. So coming to the classification, classification is very important to narrow down our diagnosis, to narrow down our basically investigation and also approach. So there are various classification systems that are useful, especially when you're dealing with children with metabolic epilepsy. Some of these sub-classification, different types of classification can be followed. So pathophysiological classification is very important to select the basically the what mechanism, what medication you're going to intervene. And based on clinical level, you can classify based on age of onset and also mostly clinical subtypes of seizure. Like I'll be giving some of the sub categories in these categories, and also the small molecule versus large molecule, and clinical perspective, it can be classified in resource setting, treatable versus non-treatable, that it can give more importance for diagnosing treatable condition as they may improve with this treatment. These are various sub-classification. If you try to classify all of them, it is good for clinician and also patient also. So this classification basically gives important clue for understanding various cause of epilepsy in children with metabolic disorders. So no need to go because these are given most of the textbooks and articles also. This is just you should be aware that these metabolic epilepsies can be classified based on age of onset. So this awareness is important because I told some of the epilepsies like pyridoxine dependency and also polinic acid response to seizures, non-ketotic hyperglycemia, they will all present in the newborn period with refractory epilepsy, what do you call developmental epileptic encephalopathy. In addition to seizures, there will be an encephalopathy also predominates. So whenever a child, especially a newborn baby with refractory seizure along with encephalopathy, you should always suspect metabolic condition, and how to go about I'll be telling in later. The later part of the infancy and childhood also various condition, especially organic aciduria, mitochondrial disorder, and neuronal serolipinosis. They can also present with the refractory seizures. So again, here also they'll be having other manifestation like other system involvement can be there, eye, ear, and also hepatosplenomegaly. In the older children, basically they will get it storage disorders, large molecule disorders will get, and progressive myoclonic epilepsy like phenotype will get. So age of onset gives what categories of disorders will dealing with these epilepsies. So this is one more chart. There are subcategories further into childhood age group. So that is similar to previous one. Again, presentation along with the seizure, you should also look for any other manifestation. If there is a seizures with encephalopathy, especially as I told, you should always think IEM, especially in the first 6 months of age. When there is a development delay, most of the times other neurodegenerative disorders like Menkes-Kinkes disease and also the serine sensitive defect, you should always consider these are some of the differential diagnoses. If there is associated dysmorphic features with seizures, you should always think those condition, metabolic condition that responsible for dysmorphic feature like paroxysmal disorder, in that Zellweger is common. And some of the mitochondrial disorders, they can most commonly pyruvate dehydrogenase deficiency can have they can have some dysmorphic feature, and congenital disorder glycosylation (CDG) also can have a lot of dysmorphic feature. Will get if there is a definite regression, if there is initially child is normal followed by seizures and regression, especially with ataxia, you should always think storage disorders in that category. Neuronal cerebral depoposinosis and other storage disorder most commonly present is predominantly seizure is lipid storage disorder like Niemann-Pick's disease and also Gaucher's disease, late onset subcategories, neuronal subtype, they can present as a predominantly seizure. And if there is a movement disorder, you should always think the treatable condition like glucose-transporter defect. So whenever a child present with the seizures, you should always look into other associated finding that gives important clue for subcategorization of metabolic epilepsies. So this is classification based on pathophysiology. So some of them because maybe in a toxic accumulation, especially amino aciduria and uracil disorder. Some of them may be energy deficiency, especially mitochondrial disorder. Some of them neurotransmitter defect like pyruvate dehydrogenase deficiency. So these children have specific features like dental variation, autonomic disturbance is the most common features. And if it is associates brain malformation, commonly seen like dysmorphic features will be associated in these conditions like paroxysmal disorder and congenital disorder of glycosylation. And purine pyrimidine defects can also cause seizure like CAD deficiency and Lesch-Nyani syndrome. And the most important subcategory in this is vitamin and cofactor deficiency. In that, pyridoxine, pyridoxal phosphate, pyotinase is the most important cause that can be easily treated. These also should be considered in the metabolic epilepsy. So these are various pathophysiological mechanism why the metabolic causes epilepsy. Basically, there will be defect in neurotransmitter ATP deficiency and also energy deficiency. These are various pathophysiology can lead to a metabolic epilepsy. Seizure types also important to subclassify and also to understand these seizures. Neonatal seizure, I told, some of the early onset metabolic encephalopathies, they will present a neonatal seizure. Epileptic spasms in many children will see a epileptic spasms. So you should always consider metabolic causes after ruling out structural abnormalities with the MRI. And in that category, most commonly you will get is a biotin deficiency, mitochondrial disorder, and sometimes organic acid. They can present epileptic spasm. Myoclonic seizures is commonly seen in NKH and also glutamate deficiency and lysosomal storage disorder like Gaucher's disease and Niemann-Pick's disease. And other phenotype that can present a progressive myoclonic epilepsy, any child with regression, ataxia, and epilepsy. In that category, most of the metabolic disorder like NCL and storage, late onset storage disorder can be present. And they can have only GTCS in case of glutamate deficiency and do syndrome like phenotype like myoclonic ecstatic seizures commonly seen in glutamate deficiency, especially any child with absence seizures. Commonly, you will see absence seizure up to 3 years of age. Any child presenting with absence seizure less than 3 years, you should always consider glutamate deficiency the most common cause. And if there is a multifocal seizure, again, you should consider a glutamate and neuronal cerebrolepinosis. Epilepsy of partial continua is most commonly seen in Rasmussen's encephalitis, other structural abnormalities, sometimes mitochondrial disorder, especially in that category. Palsy mutation melas can present as an epilepsy partialis continua. So these are the various seizure subcategories that give some idea to the metabolic epilepsy. Other way of classification is a treatable condition. You should not miss this condition and you should try to identify this condition as soon as possible because if you don't treat early, there may be irreversible metabolic brain damage that even after starting treatment, so they may not improve. In that category, most common is pyridoxine dependency, pyridoxal phosphate, and also biotin deficiency, some of the betal cofactor deficiencies, cerebral folate, and glucose transport defect. Each of them have a specific treatment. I'll be giving some of the case scenarios. These are, even though they're classified as non-treatable, but some amount of supportive treatment can be given in all these metabolic conditions. So coming to the evaluation approach, as I already told, the clinical profile is very important based on, as I discussed, in the classification, age of onset of the disease, and what is the type of seizure, what are the other associated comorbid problems like development delay, encephalopathy, dysmorphism. All those gives important clue. So you should basically fit into what clinical profile child belongs. And detailed family history is very important because, as I told, metabolic epilepsy are inherited conditions. So what type of inheritance and any significant family history gives an important clue what exactly we're dealing. And any precipitating factor that causes worsening of this condition, like high protein diet, that also gives some important clue for the diagnosis. So whenever dealing with these children, you should always take into detail of these factors whenever approaching the child. As I told in the clinical history, there will be these are some of the various factors. This is what you call stigmata of IEM. You should always look. So in that maybe abnormal size of the gate, some of them, most of them will be microcephaly, some of them macrocephaly, like storage disorders. So especially food intolerance, especially some of them may be in a protein intolerance, especially puricycle disorder. Some of them may be in a not liking some of the food, like in case of galactosemia, maybe in a milk, maybe not tolerating. Like that, food aversion gives important clue, and again a delay for the regression, dysmorphic, which I already told, and episodic course, especially when there is a worsening with intercurrent infection, you should always consider the metabolic causes. And investigation wise, there is iron in gap, you should always consider. And if there are ketone bodies present or absent with hypoglycemia, you should always consider. And involvement to other system like cataract, retinal pigmentary changes, cherry spot, organomegaly. All these gives important clue for metabolic epilepsy. You should always look when you are dealing with these children. This is a flow chart in especially newborn baby. This is given by Hailey. So whenever a child come, when a newborn child with the seizures, you should always try to. Most of the times, initially the newborn period, you should exclude the glucose and calcium problems. After continuing, you give a first line anti-seizure medication, pinovetone, and second line, if there is no response, phosphine. So if there is a no response for the first two line drugs, you should always go for the vitamin responsive condition. It can be in a sequential or it can be in a simultaneous. All can be tried like pyridoxine, pyridoxal phosphate, and polinic acid should be considered whenever a child with not responding or with two anti-seizure medication in the newborn baby with refractory epilepsy. Before maybe going for and maybe test may takes time, but you should always consider this therapeutic trial before confirming the diagnosis. So again, most of the other recommendations also same. So after clinical detailed history examination, if there is no response, especially the first two anti-seizure medication, you should always go for trial of these vitamins before metabolic and genetic confirmation also, because the early start or as early as you start treatment, the response is very good. So even though they are rare, but in the referral center they are not maybe rare. So these are some of the children with refractory epilepsy. Most of these children underwent with multiple anti-seizure medication. They have a refractory seizure with a lot of side effects requiring multiple admissions. So these children, in addition to epilepsy, these children multiple types of seizure, including spasm, myoclonic jerks, focal seizure, and also oculogyric cries, autonomic disturbance. So these children are belongs to a group of disorder, the treatable condition, as I told, the pyridoxine dependency epilepsy. So these children, all of them are responded very well with with vitamin like pyridoxine treatment, and most of them are a significant improvement, and only some of them are sequelae because of starting very late, and some of them maybe in a poor compliance. So when it's supposed to, some of the important factors in pyridoxine dependencies should, as I told, clinical suspicion is very important. Even before confirming the biochemically or genetically, you should always try to give pyridoxine supplements in the form of oral or IV based in child conditions. So especially unexplained seizures, especially newborn till 2 to 3 years of age. And in the bedside, you can see the electroclinical response with IV infusion of B6. You can see that the significant improvement with the clinically, and also the EEG will be normalized. Earlier days, you used to use routinely the metabolic screening like CSF, plasma, urine levels of alpha, EASA, and pepcolic acid. But Nowadays, less calm. You can use still there is because the turnaround time is very fast, like 24, 72 hours. Within 72 hours, you can get a level, but a lot of false positive, false negative is there. So now genetic will go directly. So, but still, it is a good test to confirm the case of pyridoxine dependency, especially you are strongly suspecting. And also, if there is a pyridoxine dependency genetic test showing VS or if it is non-negative, but despite that you are suspecting strongly, where biochemical test plays an important role. So definitely now molecular era, the WS, especially the investigation charge to confirm the diagnosis. In this condition, not only the pyridoxine, you should always give other part of the treatment like lysine restriction or arginine supplement to get the good response. So triple therapy is the standard treatment for pyridoxine dependence epilepsy. So these are all same children. They are all grown up, and you can see the significant improvement in development, especially few children because the started treatment late, and some of them are minor disability also. So this is a table showing similar to that pyridoxine dependency. There is a pyridoxal phosphate deficiency, polinic acid responsive, biotin deficiency, beta deficiency can also cause the same type of epilepsy. This is a child pyridoxal phosphate dependency. It is less common compared to pyridoxine dependency. This child has almost a normal course. This rare child, even though it is a pyridoxal phosphate, child responded partially to pyridoxine before genetic confirmation. You are thought of pyridoxine dependent, child respond pyridoxine, but there is significant improvement after starting pyridoxal phosphate. Other vitamin is a polinic acid. These children again, there are subcategories where one subcategory hereditary folate malabsorption. There is a defect in the malabsorption of folic acid to the intestine. They can present with a multi-system disorder like because folic acid is required for bone marrow growth like erythropoiesis and other cells also. If there is a defect is there, they can have pancytopenia, they can have recurrent infection in the form of diarrhea and also pneumonia. So they can have recurrent infection in addition to seizure because of deficient in folic acid. So these children can present with a refractory seizure. In addition to that, they can have recurrent infection. Is one of the common complication in the form of pneumonia or diarrhea. So these children should be recognized and should be started very high dose of polinic acid to get the good response. There is a one more condition of folate where the serum folate will be normal, but in these children there will be defect in the transport of folic acid along the blood-brain barrier. So these children present predominantly is a neurological manifestation with intellectual disability, ataxia, epilepsy, refractory epilepsy. So these children difficult to recognize and also difficult to treat. This again requires parental leucovorin for long term. It is a very expensive and painful injection also, but diagnosis is very important. The response, even though it is partial, patient will benefit. Coming to other vitamins, the betel deficiency. Betel is responsible for many of the metabolic pathways. So they can present with epilepsy. In addition to epilepsy, they can have a lot of other features like dystonia, movement disorders, and failure to thrive. So in these two important category, methylene MTHFR pathway, that is methylene tetrahydrofolate defect receptor, they will present very early with failure to thrive refractory seizures. So these children, you can see this child has significantly improved with betel supplements. So other similarly, other children where betel is responsible, is cystotheanine beta synthesis deficiency, CBS deficiency. They will present basically with thromboembolic strokes and also homocystinuria like Marfanoid habits. They can have seizures. They can have also as they can have eye myopia and lens subluxation. They may present sometimes seizures. They may also require, in addition to paradox, they may require betel supplements also. So this is so homocystinuria can be because of two defects. It can be because of MTHFR or CBS deficiency. MTHFR usually present very early with refractory seizures and also significant global development delay compared to CBS categories like Marfanoid diabetes. So other important subcategories vitamin responsive biotin deficiency. You can see this child, this infant is presented around 2 months of age. You can see so much encephalopathy, alopecia, and MRI showing almost cystic like changes, and EEG showing burst suppression, that what you will call West syndrome or infantile epileptic spasms. So, within a few months of starting treatment, you can see the significant improvement in the air changes, child appearance, and also MRI changes, you can see significantly improved. So, whenever a child with refractory epilepsy, the skin changes, you should always consider vitamin deficiency. So the simple test, the Batin assay is easily available uh, in the most of the major cities. That is a simple test, not expensive. Also, whenever a clinical suspicion, you should consider this test to confirm and is to start medicine immediately. In addition to that classical type, they can also present with the older children like West, birth suppression with alopecia. This child already, actually, before coming to us, child treated with multiple anti-seizure medication with lot of side effects, shown a significant benefit, but child improved by it in alone, and you can see the significant improvement. So they can also present in addition to seizures if their child is suffering from like these features like dystonia and the excessive skin eczema and hypopigmented hair. You should always consider vitamin deficiency. They can have like ichthyosis like this, and child go into coma requiring dialysis also. So these features also may be manifestation vitamin deficiency in addition to seizures. So if we treat these children, will improve very fast and also significant improvement. They may not require other medication. You can see most of them are looking normal without any disabilities. So similarly, there is one more condition, biting thiamine responsive basal ganglia disorders. So these children also can present epilepsy in addition to movement disorders. You can see the two siblings are presented, and this is a follow-up. This child, you can also see MRI shows significant improvement before starting, after starting with high dose of biotin and thiamine, there is significant improvement. So whenever a child with epilepsy with MRI showing changes in basal ganglia, thalamus, and brainstem, and routine metabolic, if it is normal, you should consider this treatable condition. The most common metabolic cause for epilepsy, they can present with the various phenotype. Epilepsy is one of the phenotype. They can be having sometimes also with movement disorders, and this diagnosis is important. These children will respond for a ketogenic diet, special diet that is required for these children. In addition, most of them, they may not require anti-seizure medication. So these children characteristic seizure types are usually these children get eyelid myoclonic, or what you call myoclonic astatic epilepsy, especially before before feeding they will be have these seizures, and after feeding without any treatment also you can see there is some amount of reduction in the seizures. So whenever a child with this type of classical myoclonic astatic seizures, especially before feeding in the morning with ataxia, dyskinesia, it's some amount of improvement with after feeding. You should always consider this glucose transporter defect, and especially in the early onset absence epilepsy. So simple simple test available in most of the places is glucose level. So this glucose and CSF sugar should be always be tested in suspected cases, because this is available in most of the places, and I can confirm the diagnosis later with the genetic test. So these children should be started with specific diet like ketogenic diet or modified Atkins diet, so you'll get a good benefit. So these children, as I told, is in absence seizures. This child, usually the routine absence seizure will not be so severe, and onset is very early. They may not respond. This child not respond many of the drugs currently available. Child has already tried as many drugs, but child responded with ketogenic diet. So this is a recently a published case. This child sometimes the biochemical can give overlap can be there. This child initially diagnosed with glutathione deficiency based on CSF low sugar, but later such a child not much improvement. Later done a genetic testing, it shows pyridoxal phosphate deficiency. Even though both are treatable, the treatment is different. In glutathione deficiency, this child initially a case of pyridoxine phosphate deficiency, treated as a glutathione deficiency based on CSF glucose biochemical diagnosis, but later genetically confirmed to be a pyridoxine dependency. But it is too late, almost 15 years to took the diagnosis, and child, even though responded the ketogenic diet, that is responsible for most of the drug resistant epilepsy, but not complete response. But even though it is not so late, after starting paradoxal at 15 years also, child not the significant improvement, even though not normalized. Some of the other metabolic condition you will consider is uric acid level should be considered. So these children, MRI showing like HIE, cystic hypoxic encephalopathy, but these children may not give classical history of HIE. So cystic encephalomalacia with refractory seizures, no history of HIE, you should always consider that molybdenum cofactor deficiency. You should always go for testing the serum uric acid, and also you should look for serum homocysteine. It can be less as lens subluxation and renal stone because of uric acid. And these children characteristic faces like narrow temporal fossa and long palpebral fissure, chubby cheeks. And these children partially may respond with a B6 and diet modification. Currently, there is a drug, but not available in India. Maybe some response can be there. That is a low uric acid, but other condition where you will get high uric acid is the Leishmanian syndrome. This is a child with it is an X-linked disorder, basically present in the boys. All of them are boys. So these children, in addition to dystonia, self-motivation, increased uric acid, they can have epilepsy also initially. So these children also can be treated with allopurinol. Maybe some partial response can be there. So uric acid increase and decrease also two condition can cause an epilepsy. So this is one of the other most commonly seen epileptic encephalopathy in the small babies, especially the newborn babies. So these children, this child has the refractory seizures beginning from infancy, but not significant improvement with most of the currently available drugs. And the characteristic feature that can be seen in these children is this child has an hiccups. So that is what you call a diaphragmatic myoclonus. This child has excessive hiccups. So that is a clue for this child in hiccups. You can see in the diaphragmatic myoclonus. That is a clue for diagnosis of non-ketotic hyperglycemia. So this child MRI showing a corpusculosum hypointensive corpus thinning and also signal changes in the internal capsule and the glycine level is elevated and EEG showing burst suppression. This child and routine metabolic test may be normal, but you should ask specifically the glycine level in the CSF and amino serum that gives important clue for the diagnosed pancreas where the glycine ratio will be increased. And these children may be partially treatable with NMDA receptor antagonist and also the with uh, uh, dexamethasone and also sodium benzoate may be helpful to treat partially with these treatments. Other metabolic condition, they can mimic like infection. This is a child with urea cycle disorder because of citrullinemia. Child almost managed almost 14, 15 years with dietary and supplementation. And child, because of intracranial infection, child has deteriorated and child presented the refractory status epilepticus and MRI like mimic like HSV encephalitis, but child is an high ammonia more than 500 requiring dialysis also. So this child secondary to citrullinemia. So child has a difficult course, even though child was normal for 15 years, the infection has triggered the problem. So you should always be taking care of intracranial infection, these metabolic condition. Other treatable relatively, this child has a present with the intrauterine microcephaly, mimicry like a touch infection, microcephalic cataract, child underwent cataract. This is basically a serine synthesis defect. This child confirmed genetically as a serine synthesis. Child has a significant improvement with serine supplements, even though child is intrauterine onset, but some amount of partial improvement is there with supplemental serine. And other group of disorders is cerebral creatinine deficiency. Again, it is an X-linked disorders. Predominantly, it can be manifested, it can be present in autosomal recessive also, but creatinine transport is basically an X-linked disorder commonly seen in males. They're commonly present with autism, development delay. They can have epilepsy also. The important factors to be considered are movement disorder. They can have autism, GDD, and also the MRI gives sometimes clue with the globus pallidus signal changes. But urine analysis gives important clue. Urinary estimation of creatinine and their products gives important clues, and MRS gives there is a defect in the creatine peak. Some of them will respond for creatine supplement. You should always consider supplement that is available easily. Some of the other metabolic condition, they can present the refractory seizures to the ICU setup also. The other most refractory seizure that can be present with neurometabolic disorder, Menkes-Kinck's disease. Clinical diagnosis is very easy. So whenever a boy child, it is again X-linked disorder with these skin changes, and MRI imaging shows a lot of subdural collection. Simple air examination gives important clue that in a Menkes disease, they may improve with copper histidine, air change, but neurological improvement not be so good. So again, many of the metabolic condition can be present in the same family. You should always go for screening with these children. And the most commonly seen metabolic condition can present with predominantly epilepsy also. This is a child with PKU. Child has basically an autism features with hypopigmented A with refractory myoclonic seizures. So you should always consider PKU, and simple TMS gives important clue, and treatment should be started very early, and screening is very important, even though newborn screening not available widely, but at least it is screen the family members to prevent the next babies. This is a family, you can see that there is a starting important screen. This child has screened in the newborn period, started treatment and almost normal looking. This child is diagnosed and started treatment, but some improvement. This child is diagnosed after diagnosed this child, but not much significant improvement. Other metabolic condition that can present epilepsy, especially newborn period, is an MSUD. You can see the characteristic imaging features of posterior fossa edema is a very characteristic imaging features, and simple TMS again gives a clue for this disorder. This disorder should be recognized early because some of them respond timing, and currently liver transplant is a treatment of choice. They may improve with this treatment. They can also present with this child as present with epileptic spasms with a lot of MRI changes. That can be very subtle, also intermittent tape. This child almost looking normal, especially only the infrequent seizure whenever intercurrent infection. But this child again TMS showing increased branched-chain amino acids and confirmed genetically, and MRI gives abnormal findings suggest of MSUD. The diagnosis is very important. Some of the neurotransmitter disorder predominantly they can present with seizures. But in addition to seizure, they can have other extrapyramidal symptoms, ataxia. So this child initially present with a refractory seizure. In addition to extrapyramidal symptoms, ataxia, the child has improved with even though the specific medicine currently not available, the child has responded for syndopa. He can child almost becoming nearly normal with the treatment, avoiding other anti-seizure medication. So neurotransmitter disorder should be considered whenever child has, along with other features like diurnal variation, especially more in the evening time, and dystonia, and also autonomic disturbance like excessive thing, and improves with sleeping. You should always consider. Some of the routine metabolic condition also can present as seizures. You should always consider whenever child is unexplained seizures. So glucose metabolic condition, especially newborn babies, hypoglycemia is the most common cause. So whenever a child is a macroglycia and these features are there, so you should Beckwith-Wijman syndrome. They can have hypoglycemia that should be corrected instead of treating with anti-seizure medication. Similarly, hypoglycemia because of growth hormone deficiency also can present hypoglycemia that also should be considered. Some of the common metabolic like this child is treated with multiple anti-seizure medication for many years without significant response. And this MRI gives changes in the basal ganglia suggest of metabolic disorder, but CT scan done retrospectively showing class calcification. Basically, this child is suffering from hypoparathyroidism, causing low calcium, causing refractory seizure. So just simple correction of calcium with vitamin D doses, child normalize, and all anti-seizure medication is stopped. Child has shown the photograph, child almost nearly normal without any anti-seizure medication. Similarly, the hypocalcemia can be because of many of the metabolic genetic. It can be a simple nutritional D3 deficiency also, or it can be some of the inherited metabolic like vitamin D dependency rickets also with alopecia you can see. So in refractory cases, you should always consider metabolic causes also. Similarly, hypocalcemia, there is a condition called hypomagnesemia that also can produce with hypocalcemia. You should always consider refractory hypocalcemia. Magnesium level should be done where magnesium correction should be required to correct the seizures. Some of the other rare metabolic conditions with routine metabolic abnormalities like hypokalemic metabolic alkalosis, that what you will call the Sisson syndrome or Reese syndrome. So even though they have seizure, but specific electrolyte abnormality gives important low potassium, low magnesium, and metabolic alkalosis. They can resemble with other syndrome like Bartter syndrome. So these children also improves with magnesium supplements. So most of the investigation I covered, so along with case scenarios. So the specific investigation, how these investigation helpful, I'll be giving some few points. So complete blood count is very important. As I told, some of the metabolic condition like organic aciduria, they can have pancytopenia, bone marrow suppression. And the chemical analysis, the important, as I told, important glucose, electrolytes, magnesium, calcium, uric acid, including alkaline phosphatase, gives important clue for routine metabolic condition. They may present as a refractory seizure initially, and the specific metabolic testing like organic acid and mitochondria, you should always check for lactate, pyruvate, ammonia, bicarbonate, and also followed by TMS and GCMS may require if you are strongly suspecting. ABG is very important to look for anion gap. Ammonia you should be conducted and should be done in the fasting and should be analyzed very fast to prevent the false positive rates. To get the correct value, ammonia should be always be considered because it should be treated urgently to get the good response. TMS and amino acid also gives given some of the examples how it is very important to diagnose this condition with the TMS levels. Homocysteine has elevated most of the homocysteine beetle cobalamin defects, and it should be treated with pyridoxine or beetle and folic acid also required. Uric acid, I already told, it can be low or it can be high also. Copper and ceruloplasmin is changed in case of Menkes disease and it should be treated with copper histidine. And VLFCI's levels is required, especially for suspecting paroxysmal disorder. They may be having clinically dysmorphic features and malformation of brain. As I told, vitamin SA is easily available, simple taste, low cost. That should be considered, especially for suspecting vitamin deficiency. And transfer assay electric analysis not routinely used because of not easily available, but may be useful in case of cognitive disorder glycosylation. If you are suspecting PDE, you should always go for pipecolic acid if there is a conflicting or if you want to get early diagnosis. Alkaline phosphatase will be changed in what do you call pigopathy. They can present also again in the refractory seizure. CPK is elevated sometimes dystrophlogenopathy and vacuolated lymphocyte, if you are aware, it may be useful to diagnose NCL. Urine analysis is also important. Maybe sometimes, as I told, uric acid stones, xanthin stones, urine ketone bodies. Urine organic acid analysis is very important for diagnosis of organic acid mitochondrial disorders. And creatine defect also is important test in this condition and also in case of the NK, the pyridoxine dependency, the urine level should be done to diagnose pyridoxine dependency when the genetic tests are not available. And the important other test can be done is CSF glucose, especially useful in case of glutathione deficiency. That also is useful in mitochondrial disorder with increased lactate and also pyridoxine dependency condition and also some of the neurotransmitter disorder currently not widely used because of non-availability and difficulty in transport. So whenever a doubt and if you want a fast diagnosis or in VS diagnosis rate in case of NGS, you should always consider these biochemical markers to confirm the diagnosis. And also, they are also important to monitor the treatment, but currently not widely available in Indian setup. These neurotransmitter also should be considered if possible. I'm not going to details of other things. The other important tests that are useful is MRI. MRI pattern gives important clue for what disorders you are thinking. That also gives important clue. And the other is an MRS. MRS also, some of the metabolites can be detected in the MRS to help the diagnosis. And EEG patterns like hypsarrhythmia, burst suppression, sometimes gives important clues for underlying metabolic condition. And this is a general approach. So the metabolic epilepsy should be considered, especially if there is along with the seizure, if there is other manifestation, like especially encephalopathy, And you should always try to get the baseline clinical profile, the basic metabolic workup. If diagnosis is achieved, you should treat accordingly. If not possible to achieve specific diagnosis, always go directly for the genetic whole exome sequencing because the yield is high. Then the confirmation also easy. This is a similar test only. Similar. Coming to the treatment, as I told, many of the metabolic condition can be treatable like pyridoxine dependency, pyridoxal phosphate, vitamin deficiency, glucose transport defect with ketogenic diet, biotin thymine responsive basal ganglia with high dose of biotin thymine, serine synthesis defect with serine and glycine, molybdenum cofactor. This medicine currently not available, cyclic pyrantyrin monophosphate, but at least you can try with the dietary modification of pyridoxine. Cobalamin defects can be treated with the cobalamin. Cerebral folate should be treated with cholic acid. Creatine deficiency, already three subcategories are there. Most of them respond to creatinine, and GAMT subcategories may require arginine restricted diet and ornithine supplements also. Pyruvate reduction deficiency is basically mitochondrial disorder, but they respond with ketogenic diet. And this is a rare hypoglycemia, so where they may require for seizure management sulfonylurea rather than anti-seizure medication. And triple HA syndrome, again, they require diazoxide, protein restricted. Many of the neurotransmitter defects, similar to PKU, they require dietary restriction with phenylalanine and supplement with Syndopa. And some of them respond for gene therapy also, even though it is currently not available. And important thing you should aware that some of the anti-seizure medication should not be used in metabolic condition, especially valproate, that can aggravate many of these metabolic problems. So whenever suspicion of metabolic condition, better to avoid valproate. And in addition, some of the ketogenic diets, some of them indicated, some of them may not be indicated, may worsen, especially fatty acid oxidation defect. So these in general rules of anti-seizure medication. Sorry. So management of this is a guidelines given by Hailey for management mitochondrial disorders. How to manage these children based on seizure subcategories. Mitochondrial disorder can present any subtypes of seizures. These are examples I have given. Some of the examples, what type of seizure and what type of mitochondrial disorder can be presented. So whenever a child, adult children focal seizure, the drug of choice is levetiracetam or lamotrigine. If the child, in the children again, the drug of choice focal seizure, levetiracetam or lamotrigine. For adult with generalized seizure, again, levetiracetam is the drug of choice, and children also levetiracetam is the drug of choice. But I'm not going to details of how to manage if there is a refractory seizure. In case of myoclonic seizures, even though the mitochondrial disorders, after excluding and taking specific precaution, they will advise sodium valproate can be given with monitoring. Otherwise, it can go for levetiracetam. But especially if there is a epileptic spasms are there, you should always go for steroid or rigabatin rather than going for treating with regular anti-seizure medication. They may require sometimes these drugs, even though corrective metabolic problem as detected, especially in pyridoxine dependency, even though pyridoxine were given, they can present despite pyridoxine epileptic spasm where they may require these medication temporarily. So again, status epilepticus should be managed as usual, but you should avoid sodium valproate as much as possible. To conclude, there is metabolic epilepsies are responsible for a significant number of children with epilepsies, and it should always be considered. The approach with various phenotype based on age and associated comorbid condition manifestation gives important clue, and especially the investigation like routine metabolic screening and also the MRI EG gives important clue for the diagnosis. Currently, with whole exam NGS platform gives an important test to confirm these condition, and I should always consider these vitamins, especially if the undiagnosed in suspected cases, early as possible to prevent the damage and irreversible condition. So recently, some of them are treatable with ERT and also gene therapies. So basically, our aim is to diagnose it very early, and you should start start medicine as soon as possible to prevent the complication and also irreversible brain damage. Thank you.
Thank you, Dr. Vykunta Raju. So it was really insightful. And now we will take up some questions from the
Yeah,
audience. Yeah,
yes.
because Bhatia has two interesting questions. I'll just read that out. Can universal newborn screening prevent metabolic epilepsy?
Yeah, many of them can be prevented. Not all of them can be prevented, especially like biotin deficiency, where the currently available that depends on again what newborn screening you are advising. How many panels are included in that, whether a regular basic version or expanded version. Based on that, you can many of the metabolic epilepsies can be diagnosed and it can be prevented.
Okay. So from Vikas Bhatia, we have the second question also. I think we
Yeah.
lost that question. Yeah. So basically, he wanted to know how many children with epilepsy, metabolic epilepsy, are currently reported or currently diagnosed in India. What's the number?
As such, statistics wise, I'm not aware, but most of the metabolic epilepsies reported in all over the world, you are also there most of because nowadays you are diagnosed very rare, ultra rare disorders also. What are the reported in the literature? We are most of them are there.
Thank you. So from Kannan, we have some questions. With a
Yeah.
nutrition deficiency during pregnancy has any role?
Yeah, so nutritional deficiency, especially at some endemic area, there are a lot of false belief in some of the communities. They should not eat some of the food. A lot of restriction of foods are there. So these food restriction can cause deficiencies, especially the cofactors that is responsible many of the metabolic condition like betel and also thiamine. Many of these are deficient in restricted diet. These can cause a defect in the metabolic pathways. They can present with epilepsies. So this is indirect role, and maybe we don't know a lot of epigenetic factors also plays a major role. So they may present in a nutrition deficiency also can present in epilepsies, mimicking like a metabolic epilepsy. Should always be considered because it is easy to treat on temporary treatment rather than metabolic condition where genetic defect may require lifelong treatment.
So the second question from Kannan is, so many disorders in newborns. So how to improve while moving forward?
Yeah, already there is set protocols are there. Newborn screening is especially expanding, and many of the countries are expanded to detect early newborn screenings. So the lot of public and also political issues are required to diagnose. Even though you are aware, many of the these disorders, even though now genetic also plays an important role. Now many of the countries are using NGS as a screening for these newborn metabolic disorders. So there is a role that you can prevent many of the disorders. You can diagnose early also. So requiring diagnosis based on what phenotype child is having, you can most of them you can diagnose clinically also very early because the investigation nowadays is easily available compared to what was there in one decade back. So most of them you can diagnose very early.
So question from Aman. So there is a situation where we see DRE without family history and all the metabolic EEG, MRI are normal. How would you approach such a case? Is genetic to be considered in such case?
Yeah, if there is a negative imaging, MRI is normal because structurally we can rule out many of the condition. In that condition, genetic like channelopathies, many of the genetic epilepsies, they can present with, like this. But most of the metabolic epilepsies, with the exception of some of them, like creatine transport defect, even though they are also abnormal, most of the metabolic epilepsies, some abnormalities will be there in the MRI, and clinically there will be some encephalopathy felt with the exception of few. But in that condition, usually the genetic epilepsy, like channelopathies, various other genetic cause of epilepsy is a major role, where genetic testing gives an important clue for the diagnosis. So there is a lot of overlap between metabolic and genetics. So genetic test should be considered in always with drug-resistant epilepsy, especially the MRI is negative before undergoing for any expensive treatment like surgery and other things.
So the next question is whether all the metabolic epilepsy is caused by genetics or SEN1A mutation causes the hypoathemia in children? Can it be treated? So I think there are two questions here.
Yeah, so most of the metabolic agitated inherited condition, there may be some XML epigenetic, most of it will consider genetic, but regarding the SCN1A, it is basically genetic epilepsy, it will not be considered under metabolic, basically the channelopathies. So they will present what you call Dravet syndrome. They can present with refractory or focal seizure, initially focal clonic pupil seizures, especially in the small babies less than 6 months, requiring multiple admission, initial normal development, normal MRI, normal EEG, normal metabolic workup also. You should always consider Dravet syndrome. These children are initially difficult to treat, but some of the anti-seizure medication helpful. The prevention of recurrent infection and temperature may be partially helpful to prevent the recurrent episodes of seizures and status epilepticus. Basically, the diagnosis is important to avoid the sodium channel blockers that can increase some of the anti-seizure medication. Whenever focal seizure, you will use the sodium channel blocker as a first line drug, but it should be avoided in these children. That will help.
Thank you. So, one question. So, from the Indian context, where resources are very limited, which metabolic syndrome do you think is most should be focused on?
Regarding the diagnosis or management,
Diagnosis.
diagnosis vitamin deficiency is a one that is a simple vitamin. Most of them they present with epilepsy early before skin manifestation may not be required always,
Mhm.
and pyridoxine also. Even though it is said and done that pyridoxine, the classical teaching is whenever you give pyridoxine, they will improve. And if there is no improvement, you should stop. That is not the correct case. But many of genetically confirmed cases may not respond all the time with pyridoxine. Despite pyridoxine, those genetically confirmed pyridoxine, they may get seizure later also. So a lot of problems are there. So you should always come pyridoxine also. Many of them may be missing and they may die also.
Okay. Thank you, Dr. Raju. It was really a wonderful session. It was really insightful. I would like to take this opportunity to thank all the participants who have taken up their time and been, and Dr. Vykunta Raju for this insightful session. Thank you, everyone.